Friends, welcome to my workplace at Ranaghat, West Bengal, India. Let us observe pre-chopping of this cataract, which at this stage appears hard. But initially, when I am at the initial steps of the surgery, the cataract appears soft. So, stereocoaxial illumination is deceptive sometimes. The brown cataracts can transmit a lot of light and it appears actually soft. So let us observe this surgery totally unedited. This is the main wound. It is being made with a 3 mm steel keratome, and the incision is on the posterior aspect of the limbus. The anterior chamber has been filled up with 2% hydroxypropyl methyl cellulose. Now this is a side port on the left side of the main wound, about 3 clock hours away. If you make the side port 3 clock hours away, it can reduce some amount of astigmatism induced by the main incision. Now Capsulorhexis. Capsulorhexis is being done with the help of utrata forceps. Friends, you must learn utrata forceps because in intermittent cataracts you should not use needle. In intermittent cataracts you must use forceps. And now hydrodissection. A 27 gauge cannula at a 2 cc syringe is taken for hydrodissection. The fluid wave has gone to the other side, the nucleus is tapped, and the fluid wave comes across the equator anteriorly. When it comes anteriorly across the equator, you understand that the hydrodissection has been complete. Now viscoelastic substance again, and now prechopper. The prechopper goes through the main wound, nucleus sustainer through the side port. The nucleus sustainer hooks the equator. The prechopper goes just in front of the rhexis, and two instruments come to each other. This is real time, and we have got a very nice crack. This is another. The heminucleus is held. Always you should hook and the ball tipped nucleus sustainer. The ball should go to the posterior surface of the nucleus or the epinucleus, and we have divided the nucleus into 4 pieces. Now imagine if you use any other technique like stop and chop or divide and conquer technique. If you make a trench, how much ultrasonic energy you are going to use? If you can do this, this must work with just 2 simple instruments. You are on the safer side. And now you just have to go with the handpiece, separate the pieces and pick up the pieces and emulsify the pieces. Ultrasonic energy used at this stage is 75% ultrasonic power, 48 ml per minute is the flow rate, and 480 millimeter of mercury is the vacuum. So we have emulsified the pieces. This is the 3rd piece. Any big piece we can hook the equator and divide into smaller pieces like this. And if this at this time I am trying to tilt and hold the nucleus. Yes, it is done. So during emulsification of the last piece, always reduce the parameters to some extent. I use 400, 40 and 70. 400 vacuum, 40 flow rate and 70 power. Now at this time I am planning to remove some cortex by the handpiece itself. At this time go to IA mode, and on disclaimer at this time, if you find this dangerous, please use your own safe technique. And now cortex has been removed. We just have to implant the intraocular lens. So I'm going to check if how is the loading. Yes, the loading is okay. But the haptic is protruding anteriorly, so I ask for viscoelastic substance. No, this is a polishing of the posterior capsule by the irrigating probe only. Now the anterior chamber is filled up with viscoelastic substance. Anterior chamber and the capsular bag, the open capsular bag, is filled up with. And now a little enlargement of the main wound is done, about 1.1 or 0.2 millimeter, because I am using a B cartridge. The B cartridge doesn't engage nicely in the small wound, so we should enlarge it a little bit. Here goes this is the reason I used viscoelastic substance. When the anterior haptic is protruding, it is not folded at the haptic optic junction, it is better to use viscoelastic substance. Or if you do hydroimplantation, you have to bend it with your left hand instrument that goes through the sideboard. And now, since we have used viscoelastic substance, we have to dedicate 1 minute more for nice cleaning of the viscoelastic substance. I usually clean thrice. First with this Simcoe cannula. This is a 23G Simcoe, irrigating and aspirating both the anterior chamber and the capsular bag. At this time, the anterior chamber, aspirating first, initially irrigation only, and then irrigation and aspiration. And now I take the bimanual irrigation aspiration because some more viscoelastic substance is still there. Irrigating the anterior chamber, and now the irrigating probe goes behind the lens, that is in the bag, and again it comes anteriorly, and it is done. We have nicely cleaned the viscoelastic substance. This is moxifloxacin. The side ports are closed by corneal stromal hydration. I usually don't hydrate the main wound, but if it leaks, I hydrate sometimes. Sometimes I make Ong's pocket and hydrate the pocket. So it was not necessary. It is not necessary in almost 99.5% cases. So this is the final lavage, and this is formation of the anterior chamber. See how the Simcoe was kept at the tunnel for formation of the anterior chamber. And now integrity of the wounds are checked. We should see there is no leakage of fluid through the wounds. And this is application of moxi, and then the case is concluded. Thank you very much for your attention. Hope this video will inspire you to use prechop and use less amount of ultrasonic energy. And thank you very much for your attention.